Welcome, everyone. Good evening. My name is Uri Cohen, and I'm the Executive Director of the Slifka Center for Jewish Life at Yale. And together with Rabbi Jason Rubenstein, the Howard M. Holtzman Jewish Chaplain, I want to welcome everyone who's joined us tonight for this evening's Slifka Online Salon entitled Learning from the Pandemic, Medical Education in a Post-COVID World, with Dean Nancy Brown of Yale, of the Yale School of Medicine. She's the first woman to hold this post, and she's active in the Jewish community, so there are two pride points for us to celebrate tonight here at Yale during Women's History Month. For those who have read Dan Oren's book, The Jews of Yale, the Yale School of Medicine has a long and varied relationship with Jews. And so it's indeed thrilling to have Dean Brown here as a part of the Yale Jewish community and as the leader of what will undoubtedly be a sea change in the field of medicine coming out of the pandemic. Dean Brown, we're so thrilled that you've chosen to be with us tonight, and we look forward to a great program. More on that in a moment. It's been a year since the onset of the pandemic. It's hard to believe it's been that long, and yet it's been a really long year. Along with everyone else, I've been doing some reflecting on what it was like a year ago. I remember, I think it was Purim afternoon, as it seemed that things were starting to go, to get really serious, calling our staff back to campus that next day for one last time. To prepare to get what you need to work at home for a long time. And that long time, of course, is still going as it is for so many of us. The pandemic has changed so much about our work. Everyone, I'm sure, can say that. It was certainly true at Slifka as well. We've pretty much reinvented everything with students being remote. Mental health has taken on entirely new dimensions and new challenges. Students are dealing with losses of family members, economic upheaval, career disruption, social isolation, so much that students have been dealing with that we've been doing our best to be there to help with. And yet there are silver linings. We're discovering new modes that are perhaps better than ones we had before. We were able to do the construction work on our building, which is currently ongoing. Those who have seen the videos that we've sent out gives you a sense of what's happening, and it's a really exciting project that we're hoping will wrap up in time for the fall semester. And I imagine that we'll have better public health guidelines, which will help us and all communities that gather long into the future. So all told, as we look to being able to come together in person as the pandemic hopefully ebbs away, and also to celebrate the reopening of Slifka Center after the major construction is complete. That's what we can think about, and that's certainly from a planning perspective what we have our eye on at Slifka Center these days. As a reminder, Yale University is granting reunion and capital campaign credit for gifts received by this coming June 30th. So this is a once in a generation, very limited window to support Yale University and Slifka Center fully. So please be in contact with me or with Jennifer Rojan Wallace or with Rabbi Jason if you have any questions. On to tonight's program. As usual, Rabbi Jason Rubenstein will introduce Dean Brown in tonight's program. He will also take questions and comments in the chat, which can be found along the bottom of your Zoom screen. I also want to thank our partners at Hillel at Home, a program of Hillel International, for their technical assistance with this program. We want to remind you again that the session is being recorded and will be available on our website along with recordings of our previous Slifka Center salons. We also hope that you'll take a moment to fill out the brief survey at the end. We're so excited to share these salons with all of you in keeping with Slifka Center's goals, to explore the intersection of what is Jewish, American, and Yale in our constantly changing world. It is now my pleasure once again to turn over the program to my friend, teacher, and colleague, Rabbi Jason Rubenstein.
Thank you, Uri, for kicking us off. Thank you, Dean Brown, for honoring us with your presence this evening. And thank you to all of you out there across the country and further who've gathered together tonight to make this a community, really. It's one of the few ways we can, really some of the only ways we can come together to be in the presence of others and to think and learn together, which is what we're here to do tonight. So Dean Brown, welcome to Slifka Center. Such it is, we'll welcome you in person also, and congratulations on your first year here at Yale. So Dr. Nancy J. Brown, for those of you who haven't yet gotten to the pleasure of a conversation with her, is the Jean and David W. Wallace Dean and C.N.H. Long Professor of Internal Medicine at the Yale University School of Medicine. You may have the longest title in the university. You're definitely outstripping the president, and comes back to Yale after an undergraduate degree here, then a medical degree at another university we don't have to name, and 28 years at Vanderbilt in the medical faculty. We're thrilled to have you here tonight, and I was reflecting on this salon in particular. One of our very first ones we ran almost exactly a year ago was with Shelley Kagan, the moral philosopher, on triaging ventilators. And here we are a year later, not in the kind of the heat of those early months of mayhem, really, kind of coming out the other side, and with the ability to kind of step back, look at all of the kind of devastation that the pandemic wreaked around the world and here at home, and begin to learn and reflect. And that's really our goal for tonight, to talk to you as one of the really people on the forefront of American medicine and the forefront of the future of American medicine, to understand what you've learned, what we've learned, or what maybe we've unlearned that we thought we knew and we're still in the process of putting back together. Before we get to that, if you could just give us the kind of lay of the land of medical education, Yale Medical School. As you may be able to remember from your days before you were a doctor, medical system is opaque to those of us on the outside. Everything we know about medical education is from Grey's Anatomy, basically. So if you could just give us a picture of, what is and who is Yale Medical School, how it relates to Yale New Haven Health, the budget, the size, the institution, nuts and bolts, and then we can jump into how the pandemic has shaken things up for y'all.
Thank you. So I'm glad you added the y'all, since I spent so much time in Nashville. But so yeah, it's been a year, March 11th, 2020, and I will get to talking about the impact of COVID. But as Rabbi invited, I want to start by giving some context about what is academic medicine at Yale and in the United States today. Academic medical centers like the School of Medicine are big operations with three distinct missions: education, research, and clinical care. But because tuition and grant revenue don't fully fund our education and research missions, academic medical centers today fund these missions in part through the revenues from our clinical work. And this is, even more complex because, of course, our hospitals and clinics are also critical to the teaching mission and to the research missions. But we provide a disproportionate amount of care for indigent and government-funded patients, so that revenue is not always so big, and how does one make it work? Well, prior to the COVID-19 pandemic, many academic medical centers dealt with this by consolidating and growing to become academic health systems, and Yale New Haven Health is no different. So we have a relationship with Yale New Haven Hospital. It's a 200-year-old relationship, but in the last, several decades, that has grown to be a relationship with a system that includes other hospitals in Greenwich and Bridgeport, Milford, L&M, and so the scope of our work has changed. Now, at the same time, nationally, the cost of healthcare is a major social factor. In the United States, 17% of our GDP or so is spent on healthcare, more than in any other country. We have an aging population. About 15% of our population is 65 years or older. We have an expensive system. We have drug costs that exceed many others. And in our attempts to reduce the cost of healthcare, we've actually greater administrative burdens. And so for every physician that we have 16 non-physician workers in clinical care. And about 6 of those are in clinical roles, but the other 10 are in some sort of administrative role. So that leads to one of the other issues that has been facing academic medicine even before COVID, And one consequence for our faculty and others in healthcare of this growth in administrative that has been very much on our mind is the phenomenon of clinician burnout. Those who choose a career in patient care, our physicians and nurses, are really motivated by altruism. They work hard, but they find inspiration in their day-to-day interactions with patients. And with the growth of these administrative tasks, they find that they're spending more and more time garnering permission for procedures or the use of specific drugs, working on the electronic healthcare record, and the toll on our clinicians has been great. Some define burnout as a long-term stress reaction marked by emotional exhaustion, depersonalization, and a lack of personal accomplishment. That's pretty worrisome if you're talking about physicians and nurses. In the research arena, academic medicine, medical centers or schools of medicine have had a tremendous impact on health in this country. And as I look at the contributions of researchers at Yale School of Medicine in just the last several decades, they include, understanding the mechanism and the treatment of Lyme disease, elucidating the genetic underpinning of many diseases, including forms of high blood pressure, the development of insulin pumps to treat type 1 diabetes. Many in the field of immunology have identified molecules that are now the target of anti-cancer drugs. The use of low-dose ketamine, previously a drug used in anesthesia to treat refractory depression, and the list goes on. And yet, until recently, I would say the public has not always been aware of how even basic science discovery gives rise to advances in therapeutics and health. And the last thing that I want to mention as I'm setting the stage here is where we are in medical education. And Yale is a school that has a relatively small class of students. We have 104 medical students entering each year, but we also have 900 residents and 400 fellows who are training in the hospital. And one of the interesting tensions in academic medicine today is between the role of our students and trainees as learners versus their role as members of a profession committed to healing. And so our medical students are just that. They're here to learn, but through rituals such as the white coat ceremony, even beginning at the very start of medical school, we emphasize that they are joining a profession in which they have obligations to patients. And so the question of how a student balances that, when are they there to serve and when are they there for the benefit of their own education, has been a tension, particularly of late in medical education. And this is more so for our residents and fellows who are actually paid to care for patients, but of course are still learning under the mentorship of senior physicians. And so I'll talk perhaps in a moment about how COVID has even further impacted that.
Wow, that is just an incredible scale of kind of framing of what you do and what medical education is. And the thing I want to really just note is how the account you gave doesn't kind of only concern itself with the classroom and then kind of begrudgingly note the existence of an outside world. You're talking about the demographics of American society, the realities of intellectual property and drug prices, and about what happens for your students as they become doctors over decades of a career, and really kind of taking all of that into the ambit of your educational mission. Not to mention the budget of a multi-million dollar organization, including hospitals, et cetera. So that's a tremendous amount to hold. And then you mentioned, right, there's COVID. COVID changed medical education, everything went online, posed a surge challenge to hospitals, from friends who worked with COVID patients in Yale New Haven Hospital, what that was like. And also we have a sense is things are not going to snap back to before, and maybe shouldn't snap back to the way they were before. So if you could give us a picture now, having laid out the status quo ante, now a year into the pandemic, what changed, what broke, and where are we going from here? What will be different going forward?
Yes, so when I think about the effects of COVID, I think in terms of kind of the immediate effects and then the lasting effects, and many of these will be common to everyone in the room, but the early effects really are about rationing. Early in the pandemic, we had shortages of diagnostic tests, we had shortages of personal protective equipment, and in some areas, ICU space and ventilators, as you've discussed, this question of rationing ventilators, which required a prioritization of healthcare delivery. And in fact, Mark Mercurio and members of our biomedical ethics community in the hospital have written about this and how it came into play in the emergency room. I would say the dilemmas that people faced were strengthened or heightened by, in the case of COVID, a very strong association between mortality and age. So as you're probably aware, 60% of deaths due to COVID occurred in those age 75 and older, 81% in those age 65 or older, and 90% in those age 55 or older. So many of the ethical dilemmas that we think about in a society about how do we treat the elderly, how, come into play here. The media highlighted dramatic cases of rationing, but during the pandemic, we made decisions with the intent of maximizing benefit to the whole that in some cases delayed care for others. For example, when we had inadequate personal protective equipment early on, we and many other institutions put off doing elective procedures. We moved patients out of the hospital into outpatient areas so that we had room for ventilators and those sorts of things. And in some cases, the delay of elective procedures may have included diagnostic procedures that resulted in delays in treatment. The pandemic has also served to focus our attention on issues of health equity. There are many diseases that disproportionately affect minority communities: diabetes, hypertension, premature birth, certain cancers like prostate cancer. But I think there was a little bit of blindness to that. And in the news every day now, we see African Americans and Hispanics are 3 times as likely as others to contract COVID, twice as likely to die from COVID-19. So that one impact of the pandemic has to refocus us on understanding why that is. And it's not always the simple answers that are the explanation. The economic impact of COVID has only accelerated that consolidation in healthcare that I described earlier. Because of decreased elective surgeries and outpatient visits in order to make room for COVID patients, there were significant declines in revenue. And CARES Act funding mitigated this for large hospitals, but many smaller physician practices were affected. And so that again accelerated that growth of large systems. In terms of our research mission, I think the pandemic has highlighted the value of research for the public in ways that no lobbyist could have ever highlighted it. Everyone has become an epidemiologist. People talk about cytokine storm and terms that they had never heard of before. What we need to emphasize is that the miracles like the development of vaccines in a year were made possible because of basic scientific research about mRNA, for example, that was done many years ago. And so that connection of cause and effect is one we need to remind people of. There will be lasting changes to the practice of medicine. The pandemic, for example, highlighted even further the need to pay attention and provide resources for the well-being of our clinicians. Many of our clinicians on the front lines were dealing with patients who were dying without their family around them because we were limiting visitation to the hospital. We had nurses who had previously worked in pediatrics and had never seen patients die, now staffing COVID units and staying with dying patients when family couldn't be present. And I mentioned this tension between learning and professionalism for our students. One of the hardest things that I have had to do as a dean so far is send students home at the beginning of the pandemic from clinical rotations because we didn't have adequate personal protective equipment to have them have a meaningful learning experience in the clinic. And that was right at the moment when students wanted nothing more than to be present. As the pandemic went on, our students have done all sorts of things, including give vaccines on a volunteer basis, and really contribute to the care of patients. The pandemic has accelerated the use of telemedicine across all specialties. That was something that most physicians were reluctant to practice because we're used to looking eye to eye with our patients and examining our patients in person, and that was something we had to get used to. I would say in the education realm, it also helped us to understand, as we were discussing earlier, the benefits of remote learning. I would say there are many who don't wish to go back to in-person scientific conferences. They find the Zoom experience a better experience. The attendance at conferences far exceeds any level pre-COVID. So we miss coming together, but we also benefit from easier access. And then a last minor thing I would mention is that we have learned from COVID lasting lessons about the supply chain and an over-reliance on a single source of goods, whether that be for testing materials, for our drugs, or for personal protective equipment. And I think that will change how we practice medicine for many years.
Wow, that is, I mean, you just covered a tremendous amount of ground again, and I want to make sure people know that in just a couple minutes, it'll be your turn to ask questions. So you can chat questions privately to me or chat to all in the group, and we will start taking those. Dean Brown will start fielding them. And I do want to say, in terms of the pride of place that medical research has in all of our hearts and minds, I certainly have never been as big a fan of any molecule as I am of mRNA. My love for it greatly outstrips my understanding of it, but I'm a big fan. So it just, yes, on that point. And I also just wanted to note the poignance of what you shared earlier about rationing care, not just in the one ventilator, two patient sense, but in a much broader sense, and the less certain senses of delaying procedures, which may delay diagnoses, which may affect lead to more adverse outcomes, and never quite being able to be sure knowing what the effects of those decisions are, the kind of heaviness that attends to that unresolved implication. I want to open up one more axis here, which we haven't explored yet, and I guess as the rabbi is my happy place, which is to hear your reflections on the science and art of healing and Judaism. I want to share with everyone, it's a rare faculty member I meet at Yale who quotes Talmud at me in our first conversation, which is what Dean Brown did, the incredible story of Rabbi Shimon Bar Yochai in the cave, and who studied at the Pardes Institute in Israel, and what areas of either kind of congruence or kind of tensions that you feel between your private, familial, communal Jewish life and then the professional register you occupy in the leadership of Yale's medical community.
So this is your happy place. This is my insecure place. As I've thought about this question of rationing, I have looked a little bit for the rabbinic thoughts about that and my understanding, and I would be very interested in your education on this, but that the Mishnah discusses this in the context of the extent to which the public purse be depleted in order to save the individual lives of those who have been captives. And I think these are questions we wrestled with as a society early in the pandemic in terms of what do we close down? What's the long-term impact on our economy, on our school children, the long-term effect of loss of jobs and therefore health insurance on chronic illness versus the short-term saving of lives. And I think it's going to be a long time before we know all of the answers to these questions. And one of the terms that I don't think I've ever used as much is in the beginning of the pandemic was the term, this is in a state of flux, or so I'd be very interested in your comments on that. I think the notion of do not stand idly by the blood of thy neighbor, which is often used as a justification for medicine, I think is particularly pertinent to how we think about health equity, and how some populations benefit more than others from medicine. And then I guess the last one, specific to medical education, for me, medical education is very much on a mentorship model. I mentioned that our residents and our fellows in the hospital are learning from senior faculty, which seems very rabbinic to me. And I often think of when the Pirkei Avot, make for yourself a teacher, acquire for yourself a friend, seems to me a very good description of how we educate in medicine. So those are a few random thoughts to get into your happy zone and my uncomfortable zone.
Wow. Wow. There's a tremendous amount here. There are two vignettes that I want to share. The first, well, I'll start with the last thing you said about the, and actually then turn it around to you as a question about the kind of disciple student relationship there, right? Make for yourself a teacher. That word in Hebrew, rav, which is related to the contemporary title rabbi. There are two different types of ravs. There is the teacher, maybe better, master of a student, and then there is the master of a slave, right? If you just see the term rav, or a servant, you don't know whether it's in opposition to a student or a servant. And that's the sense of discipleship is deeply embodied when it involves, kind of attending to someone, and it has a kind of a very powerful kind of power imbalance hierarchy, which in modern rabbinic liberal educational settings we try to kind of hide. But then thinking about medical education of the the intensity, the physicality of the work, the intensity of it, and the real degree of hierarchy. The attending has certain responsibilities and certain tasks that the students are doing, and that line between are you doing work or are you learning is very unified, I feel like, in that kind of rabbinic picture, like you described it, or the tension is very palpable in a way that it isn't in many other educational roles. And so part of what you're making wonder is there's a sense of a guild, a craft, a discipline that students apprentice to in a way that does feel very deeply traditional. And it's, and it certainly has been the kind of the way that, we have interns here. It's much less intensive than, interns at the hospital. But I think there is a parallel there. So I would wonder if you would speak to, just for a moment, to that, you mentioned a few times the back and forth between being in a service mode for your students when they're kind of operating as doctors and also being students learning, and how you balance that and how the kind of learning emerges in that space of just being able to begin to give care and kind of growing step by step.
I think one of the things that we need to do and don't always do well is teach our students how to learn in a setting that they view as service. And there may be generational differences in this, and I see that there are many physicians on the in the salon, but you know, many of us as interns spent the evening hours putting IV catheters back in patients that had fallen out, and that may seem like a service, and yet I learned so much about the experience of the patient in the hospital, not to mention how to put in an IV, but and the diseases that they had. And so I think it is in some ways a false dichotomy, but we don't do a very good job. And it's created by educators and administrators who create rules about this. We quiz our students about whether they're getting adequate education or are they spending too much time in service, when perhaps we should be emphasizing how the two are one and the same.
Wow, so interesting. I mean, I want to follow up so deeply here, but you did ask another question about thinking about the costs and the differential costs on different groups, from, you know, shutting society down and then the inequalities in healthcare treatment. And I want to just address that for a moment with what I find to be actually one of the most moving Jewish texts of the early 20th century. So I'm going to have to, as often happens, have to lay out a fair amount of groundwork to get to the punchline, but I think it'll be borne out as having been worth it. So the context is generally one is only allowed to break kind of top level biblical commandments on Shabbat to save a life. But no amount, and maybe to save a limb also. That's an interesting aside, as an interesting history, but generally save a life. And so in theory, were a fire to break out, and you knew you could safely evacuate everyone, you just have to let it all burn. And this leads to the case where a human, I mean, you can imagine that it's hard to say. So you imagine you're in your home, it's kind of isolated. There's been a lot of rain recently. There's no chance the fire is going to spread. You know, and you see an electrical fire break out, and your home's uninsured. You know, God forbid anything's happening. You're supposed to just evacuate your family, and you have a fire extinguisher right there that you could put it out. And you're supposed to just say, "Oh, I've got to walk away and watch everything go up." Flames, like your life savings and everything. And these things are hard to say, especially because, you see, right, there's actually only specific commandments that we're supposed to sacrifice everything for, whether that's life or property, and those are idolatry and a few others, but not Shabbat. And so along in the early 20th century, Rabbi Moshe Shmuel Glasner is one of the most fascinating rabbis of the 20th century, is the only Hungarian Orthodox rabbi of his generation. Writes that he says, look, I know this is the kind of black letter law, and I'm going to have to fall back on a distinction which I don't see anywhere in the literature, but I'm going to try to generate it, that this idea that you have to let all of your property go to not violate Shabbat only applies to people who are kind of well off and have a lot of human capital, right? That they're going to be less well off, but they're not going to be reduced to the degradation of poverty. But someone who is maybe, you know, elderly or infirm, or the only chance they have for income is of some piece of property they rent out, such a person is actually not commanded to subject themselves to ongoing poverty in order to save Shabbat, because, and this is the kind of amazing move he makes, he says, actually, like, there's an interesting thing, that ongoing torture, so you talk about the ethics and the way medicine and religion can get involved in that, is worse than death. There's a tradition that's built up, because death at least ends, you know, the suffering ends, whereas torture can, you know, the psychological experience is kind of open-ended as the physical pain. And ultimately, like, living a life of degrading poverty and watching one's children grow up in degrading poverty is a kind of suffering, an interminable suffering, a suffering that doesn't have a definite end, and is therefore kind of thought of in the Jewish tradition as worse than death. And therefore there's an out. And if those are the stakes, you actually do put out the fire on Shabbat. And he says, you know, the best evidence I have of this is the line, the Torah's ways are ways of pleasantness. It's like, I can't give you any better evidence for that. And I've thought about that a lot in the pandemic. I wrote a piece this summer about it, because first of all, the picture is, there's no such thing as like the economy, or, you know, GDP dropping by 2.7%. You know, it's all, well, for some people, GDP dropping by 2.7% means like their bank account only went up by this much last month. And for other people, it means they're being evicted, right? And then those are two, like to roll those up under the same number obscures much more than it reveals. And so thinking about the ways we would kind of maybe think about health impacts, differential health impacts, and certainly differential economic impacts from the pandemic would be to basically to ignore the effects on the kind of upper middle class, well-off folks, and to focus entirely on people who are most vulnerable. And this is even bracketing the fact that the wealthiest Americans tend to have gotten wealthier over the past year. And so I think it's really an attention to the places we might not look, the people we might not look at, the people who might not have as much of a economic, social, or political megaphone is where Judaism would really kind of call us to focus economically. And then also, as you said, thinking about the pre-existing life expectancy inequalities, on racial and economic lines, in the ways that those have only been exacerbated. So I do think there is a kind of a Jewish frame here, which, as I said, again, it takes a little bit of elucidation to really get to the line, but it is one that doesn't leave us in a comfortable place about where we are as a country right now or where we're headed, because it, I think, just sharpens the focus on the injustices of the world we're living in, and the world which seem to have in many ways accelerated over the past year. Dean Brown, where does that land with you?
Yeah, it's a great. I think that's a very applicable drosh, actually. You needed me to affirm you on that. So.
Okay, well, I appreciate that. So we have a bunch of questions here. So I actually want to turn the mic over to Ikenna Maduna, who's an undergrad here, one of the leaders of the undergraduate community. And would you, it's a really interesting question about kind of certain systemic biases in medical education, which are maybe coming to the fore, and what you're doing to address them. So Ikenna, I'm going to put you on the spot here, and Benjamin, could you spotlight him?
Sure, thank you for the opportunity to ask this question. I'll just read it off what I sent. My question is, given the increasing awareness of how medical education fails to accurately teach about medical characteristics that differ across populations, example that I was thinking of is racialization of medicine that you see present in the EGFR kidney test. I want to ask the ways in which you're moving to help rectify these harmful tropes in medical pedagogy.
Yeah, so not everybody will know what you're talking about with the EGFR, but so there are many things in medicine where people derive predictive formula, statistical formula, and include in that various patient characteristics, which may be, it often is gender, age, race, and then says, you can calculate the risk based on this if you include all these characteristics. And EGFR, which is estimated glomerular filtration rate, is a measure of kidney function. And the formula that is used suggests that at the same blood test value of creatinine, if you're white, you have a lower kidney function than if you're Black. And the concern is that leads to patients of African descent being put on dialysis or being treated to prevent dialysis at a later stage. And there are many, many examples of that. So I think the first thing is we have spent a lot of time looking at our curriculum and thinking about how we address those questions and make people aware of the questions. Sometimes the answers are not straightforward. I can give an example of I study a side effect of a blood pressure medication called angioedema, which is and of the face and can actually close the airway. And when I was first starting in my career, we made the observation that event is about 5 times more likely to happen in someone of African descent than of someone who's not of African descent. And so one of the questions is that racist to take race into consideration when you're prescribing that drug, or should we not prescribe that drug to patients of African descent and pick a related drug that has less risk? So there are, I think that we need to apply science in this area as much as we do in any area. And one of the things I'm very excited about is that we appointed Dr. Marcella Nunez-Smith as our inaugural Dean for Health Equity Research. And we actually just spoke this morning, and one of the first things that Marcella is doing is holding a symposium for our researchers to help researchers think, even when they're collecting samples from patients for repositories, how they think through and understand these ethical issues, but then how they apply cutting edge research to address the kinds of questions that we're talking about. So I hope that answers your question. I mean, first, looking at our curriculum very carefully, but second, I think not making assumptions and doing really careful research to understand what are the bases for differences. Are they genetic? Are they social determinants of health? And understanding which of those things come into play in what circumstances.
We have a question next from Cliff Hendler about the kind of spiritual dimensions of burnout and what you're doing to address that. Cliff, we're all yours.
Thank you, Rabbi. Dean Brown, I was interested in seeing if you could talk a little more specifically about how you tried to bring spiritual values, Jewish values, into the steps that you and your colleagues were trying to take to help physicians and nurses and other healthcare personnel address the incredible stresses and challenges that you spoke about earlier. I would really welcome if you could go into more detail there, because it sounded like that was something that you thought was a very important issue and something that you had given a fair amount of thought to.
Yeah, so I would hope that I bring my Jewish values to everything that I do, but not necessarily frame them for others in that context. There were many, many people who responded to the increased stress that our faculty and clinicians had. And many, for example, in our Department of Psychiatry, volunteered to be on call, to triage, to be available to counsel people 24/7, those sorts of things. They created surveys that allowed people to check in on a regular basis, just to ask the question, are you stressed, and complete a questionnaire and then refer people. We had group sessions that were led by some of those faculty that were extremely meaningful to people. So taking the time to pause, and I guess, the most Jewish of all values in this is the idea of Shabbat, and emphasizing that no matter what's going on, one still needs to pause and take that break. And I think we did try to create those moments for people.
Thank you for that. Now, Gwendolyn Towers, who's a fourth-year medical student, had a bunch of questions. I think we selected one about the kind of consolidation trends of the health industries. Gwendolyn?
Dean Brown, thank you so much for being here tonight. I was interested in what you said about how large healthcare corporations have been growing since the pandemic started. And I was wondering what you perceive as being the benefits and drawbacks to that, and if there are significant drawbacks, what we can do to mitigate them as we continue to grow these large corporations.
The host had just muted me. I hope that wasn't a, no. So it's not just corporations, it's not for profit. You know, it's as I said, it's academic health centers. I think there are many good and perhaps not so good consequences. There are efficiencies that allow one to provide care to more people through that consolidation. But there are also concerns that our patients who are in rural areas, for example, may lose access if their small hospitals close in the process. I would say that was more concerns 10 or 20 years ago than it is today, as what's actually happening sometimes is that a larger system can ensure the survival of a smaller member through that standardization. Where I worry about it is in the decisions that we make to grow in academic medicine. There's a limited amount of money, and one can make investments in growing the healthcare, the clinical operation, because we're convincing ourselves that we need that clinical revenue to support our education and our research missions. But sometimes the tail starts to wag the dog, and we make decisions where we lose track of our teaching and research missions. And one of the things that attracted me to Yale is that I felt like we were not doing that, and we very much had the balance of those missions correct. But that is a risk for some institutions.
Now we have a question from Alexander Cohen, who's a undergraduate and pre-med, about the inequities that are kind of cropping up and perhaps inescapable in different vaccine distribution regimes. So Alex, take it away.
Thank you so much. So thank you, Dr. Brown, for obviously being here and answering our questions. I'm a pre-med student, so I've been attending a lot of, the COVID-19 colloquiums, and I was just wondering, how can we sort of mitigate health inequities with vaccine distribution, especially since more vaccines are being produced? How are we able to get them to either communities that aren't able to access them, or to rural communities and stuff like that?
Thank you. I think there are real concerns about distribution. It is about inequity in terms of groups not becoming equally vaccinated. It is not always about distribution. One of the biggest issues with which we deal is vaccine hesitancy. And these are new vaccines, and for some there is fear, and we have lost the trust of some populations because of some pretty awful history. If you think about Tuskegee and studies like that, where we absolutely used certain populations, it makes it harder even 50 years later, 60 years later, to come back and say, well, there's this new vaccine and we're all taking it and it's okay, it's safe. So a lot of the work that we've been doing, we at the school have an extraordinary group of partners called the Cultural Ambassadors, who are the pastors of the AME Zion Churches of Connecticut, and also members of Junta for Progressive Action, who have been partnered with us for about 10 years to increase participation of underrepresented minorities in clinical trials. And during COVID, that partnership pivoted in that we started having weekly town halls that the cultural ambassadors hosted to help groups learn how to get access to masks, how to social distance when it didn't seem possible, and most recently to educate on the risks and benefits of the vaccine. And I can tell you that it's very compelling to hear Reverend Perry or Reverend Clayton say, I got vaccinated in the trial, and I got the vaccine, and let me tell you, this is a gift from God. That's a pretty powerful message. And so we are doing a lot of outreach to try to get, make sure that we get vaccine out to all populations.
Wonderful. Wow, yeah, that's the work we're gearing up for now as a country, and so important. Next, I have a question from Diane Kamenis about whether you're establishing a Department of Telemedicine going forward. Diane, you're on. Let's see if we can get the spotlight over to Diane. Well, Diane, even if we can't see you, I think we can hear you. Oh, there we go. Perfect. You're muted there. Oh, Diane, you're muted. Can you unmute there?
Unmute.
There we go.
Okay.
Perfect.
Thank you for taking my question. I was wondering, have you created a new department of telemedicine? And if so, what will be its mission?
We have not, because I think the technology of telemedicine crosses all departments, but there are still some things that we need. First of all, I think there are wonderful opportunities to continue to develop technology so that we can actually examine patients virtually. You know, there are all sorts of sources of information in people's homes now, whether it's their Fitbit or their home blood pressure cuff. So coupling that with telemedicine is something that lots of folks are working on. I think the other thing, the work that we need to do is define better when it's okay to do telemedicine and when we really need to bring patients in and examine them. I had the experience of having a family member who was ill at the beginning of the pandemic, and there was no doubt in my mind that he received less adequate care because people were examining him over the telephone, over telemedicine, or at a distance, and the condition that he had was not amenable to that. So telemedicine is not the be all or end all. It is, again, you know, as a blood pressure doctor, for me, a lot of times when I'm talking to my patients, I really don't, you know, once I've examined them, if there's nothing going on, I can, you know, change their medicines over the telemedicine. I can look at their numbers, and there isn't a need for me to see them every time. But we have not done a good job of defining that, and we need to.
Thank you.
It's 8:55. I'm going to pause for station identification with a round of thank yous. First, again, to Dean Brown. It's been just fascinating to hear how your mind approaches this diversity of interlocking areas, and also just to note your effectiveness as an educator here. The chat has been buzzing with questions, including from students, which isn't always the case in these evenings, and I think is just kind of speaks to the ways you've drawn out the questions that are on people's minds and hearts throughout the pandemic. Also want to thank my colleagues at Slifka Center, Ori Cohen, incredible executive director, Jennifer Rogen Wallace, our development director. I saw Lynn Jackson Quinn is on here, and Benjamin Laufer, once part of the Slifka family, always part of the Slifka family. And again, to all of you for really making this a community of learning and inquiry tonight. Next week at exactly this time in, 167 hours and 4 minutes, we'll be gathering again to have Mark Gerson, who is an alumnus of Yale Law School and the host of the podcast with the fun title, The Rabbi's Husband, where, full disclosure, I was interviewed earlier this year. Mark has a new book out called The Telling, which is a translation of the word Haggadah into English, the subtitle of which is How Judaism's Essential Book Reveals the Meanings of Life. His tagline for his talks that he's doing now are, God didn't create the Seder to put you to sleep. A little more critically and historically minded, like I am, say God didn't create the Seder, period. It's from the Second Temple to your decline, but it's going to be really fun. It's a lively book. I'm working my way through it now. So that'll be 8 p.m. next Monday night, and no registration required. Just show up on the Zoom link that's flying around. I want to just send one last question your way, Dean Brown, which is, I remember when we first spoke, you mentioned burnout, not just from, having patients who die, but also from the kind of vagaries of a career, which can, inevitably has its disappointments. And even the most successful careers, I remember you saying, some, doctors, very successful PIs will look themselves in the mirrors when they're 50 and say, this isn't who I wanted to become. I wanted to heal people, not just win multi-million-dollar grants from NIH. And so I would love to hear from you the kind of personal stories of inspiration and of solace that have, allowed you to deal with the inevitable frustrations in a career like you've had, and also to make decisions at kind of critical moments that have kept you on a path where you feel like you're able to live your values and keep doing and growing the hopes that brought you into the work of medicine decades ago.
So I would say, I will repeat again, I think the importance of Shabbat or sabbatical as we use it in academia, but the importance of taking time out for reflection is one thing. The importance of mentorship. So I guess we're getting back to the teacher and having those people to whom one can turn for advice. And in my case, and I have to say this because there are a couple of them on the Zoom, but the importance of family as people who provide perspective.
That is advice we can all take with us, and I hope we all will as we go through these times. I think the ability to take time out. I just want to share this. I don't know how it got on my Twitter feed, but there's a Jim Beam ad going around that says, "At what point in your pandemic did working from home switch to sleeping at work?" And I think for all of us, probably the sense of the kind of oppressive omnipresence of work is real. And so the ability through Shabbat, through family, through conversations that are not about checking something off your to-do list, but both getting outside of work and also going deep into it to understanding the why and kind of savoring the problem and the opportunity is something coming from someone you at the very peak of your profession. And that is my 6-year-old asking me, is it 9 o'clock? Because I promised him that if he would hold it together for this hour, he could tell me the 2 jokes that he came up with during our salon. So in the interest of family, and he gets a quarter, that's right also. Thank you for reminding me. In the interest of family and keeping our word, I again want to thank you all for this gathering. Thank you, Dean Brown. It's wonderful to have you as part of this community, such a leader and educator. And see many of you next week at 8 p.m. And for those of you I don't, I hope you have a Zis and Pesach, a sweet, sweet, rejuvenating holiday where some liberation and hopes of redemption and the possibility and realization of redemption come into your and your family's lives. Be well.
Thanks again, Dean Brown.